Good morning from all around the world and welcome to Structural Heart Life Cases, broadcasting directly from the cardiac catheterization at the Mount Sinai Hospital in New York City. I'm Pedro Moreno, your moderator, and we would love to hear from you. So please send us your questions. Do it from the website or do it from YouTube. But we love to hear from you. Most importantly, you can review this case as well as all our previous structural heart life cases in our website, ccclifecases.org. And now I'm going to transfer you to the cath lab for a very interesting case.
Where are other people?
Yeah, the first one, I think we should have the lights on. Okay, good morning to our viewers of CCC Live. Although we should change the name, but it's not a complex coronary case. It should be complex structural case. So CSC, we're trying to change the name. So it's a structural case, and endovascular should be a peripheral case, CPC. But anyway, that will be the new, but welcome all our viewers and keeping us on our toes and try to show something different, and knowing that in the TAVR field is less decision making has become quite simple, but this case we show the challenge of the smaller annulus which we had trouble. So with that note, all the presenters, associates, everyone here with Dr. Keeney, Dr. Kera and Gilbert and our fellows, can't even see.
Krishna and Gaurav.
Okay, so all the good team, and then of course rest of our staff, and on the echo, Dr. Larakas. So all will update this per case, which these are our faculty involved, and cardiac anesthesiologist Dr. Raphael Honigman. With that note, this is the case we are going to show use of the Evolut Fx plus TAVR for extreme risk AS patient with a small aortic annulus. So this is the case, 89-year-old female who presented with a shortness of breath and fatigue, good with some risk factors, other well controlled on medical therapy, but severe aortic stenosis. Will show that. Lev-wise okay, and creatinine is good. And average, BMI with 29, with the EKG showing normal sinus rhythm, and cath was done today, which has a non-obstructive CAD. So with that note, we'll show directly with the Larakas, show us about the aortic stenosis. Here is a quite severe with a velocity of 4.1, and we can go to the live echo now, please.
We see the echo.
Yeah.
You can calcified. No valvular AI, no significant mitral regurgitation, no pericardial effusion, normal RV function, minimal tricuspid regurgitation. As you can see, the aortic valve is thick and calcified. The leaflets don't move. No much AI. Normal LV, normal RV function. Minimal, mild mitral regurgitation. As you can see, the gradient is 4.5 with peak gradient of 80, mean gradient of 55. Aortic valve area of 0.7 centimeters square, stroke volume index 49 ml per meter square, so it's normal flow, high gradient, severe aortic stenosis. The same here, turbulent flow through the stenosis, and no pericardial effusion, subcostal imaging. Thank you.
Beautiful.
Thank you,
All right, so it's a form of clear-cut severe aortic stenosis, which high calcium score, no much regurgitation, good left ventricular function, as had been shown. And now we are here with a CT, and where it was said that it will be a smaller annulus. Gilbert, who wants to talk about SILE on the CT findings?
Sure. Thank you, Dr. Sharma. So less than 430 millimeters square, you can see a SMART trial patient here. The perimeter is 68 on the annulus. The LVOT really narrows down to 56. So truly a small annulus patient here, and would have qualified for the SMART trial.
Yeah.
The STJ is around 25 and 27. The sinuses are reasonable. The right sinus is 30 and the left sinus is 28.5. The left coronary height is 12 and the RCA height is 19. So reasonable to consider a self-expanding supraannular platform here for hemodynamics.
So Gilbert, based on this, it does not look any hostile anatomy, right?
No, I think it's pretty straightforward. You can go to the next slide. And this little bit of horizontal aorta, you can see 60 degrees. It will show you on the aortogram. I think that's probably the only tricky spot, but this is trileaflet calcific AS should be a classic case for TAVR.
Okay, beautiful. Okay, and access-wise?
Some calcification on the right side, but the left looks pretty reasonable, and you have moderate tortuosity.
And good lumen with that. So now question is which type of valve is fit in. So based on the annular diameter and perimeter, it's a 26 millimeter Evolut Fx plus. Right, agree with this is the best system scenario in this. So basically that's our plan is now using 26 millimeter Evolut Fx plus for this severe extreme risk aortic stenosis using femoral arterial access with the main access is from the left side based on the tortuosity. So let's show what you find on the angiogram and the aortogram.
Sure. So we can go over the, this is our cusp,
Can we go
the
to
coplanar view.
fluoro view,
Fluoro,
please? Thank you.
So first view is always our coplanar view. I want to make sure you have your 3 cusps there. Then you go to your cusp overlap view where you isolate the non-coronary cusp on FOSS to start your valve deployment. We also do a coronary angiogram, which I'm going to show you here. So some mild, moderate RCA osteal disease, otherwise looks non-obstructive. The left side tortuous vessels, but non-obstructive CAD, LAD, and circumflex look okay. The left main looks okay. And your coronary heights are pretty generous, so I think we should be okay from a supraannular valve standpoint.
And you have aortogram there. You saw it aortogram. So based on, no, it looks like, didn't look horizontal. It looked more on the CT, a little horizontal, right? Here is any challenge?
Okay, no.
Yeah.
Let's go back. Let's go some basics here.
Yeah.
Go back to the slides because every time we keep the numbers. I think people who are watching should get some concept of what's the norm. Go back.
Let's see the aorta, please.
Go back. Back. Back.
This is one.
Yeah, back.
And this is the main one.
Okay, so why we said that it is a small annulus?
Yeah, so if you look at the SMART trial, Dr. Kinney, 430 was the cutoff for small annulus in terms of the area. Here the area is 355.6. So you have, this is truly a small annulus patient. Anytime you're using a balloon expandable valve, which is 23 or lower, it categorizes as a small annulus because we have seen these patients end up having higher gradients. And if they're not matched to their BSA or BMI, they end up having higher gradients and sort of worse outcomes. So really have to think about these patients. If it was more than 430, we could have, choose either valves, but you have a very small annulus and your LVOT really tapers down. So that makes it very tricky in terms of using a balloon expandable platform, not just for hemodynamics, but also for safety standpoint, because the valve remains under expanded, the durability also goes down.
So the key is the area derived by the CT is the criteria which we call a small annulus. And less than 430, there have been some numbers in the past also, but majority knowing the SMART trial, which compared the self-expanding versus balloon expandable, yes, anytime you 23 millimeter balloon expandable valve is small, but the definition basically was less than 430 millimeter square is your area, which called it a small annulus. Yeah.
Where does it? We highlight next time.
Well, I think the main thing also to comment is you look at the average diameter. I think it's 21.3, 21.4 on the annulus. So, then that putting a 23 millimeter balloon expander is going to be underexpanded. It's not going to go beyond that. Otherwise, you have a root rupture. So I think even if you do a 23, we would have taken volume out. If you go to the next slide, I think it's very important to see the calcification pattern.
Pedro Moreno, are there any questions related to this?
Next slide, Dr. Sharma.
Not yet, but the comments are well taken. Very, very important comments.
Yeah,
and then the heights of the coronary.
But look at the top right panel, aortic valve calcification. Very heavily calcified trileaflet valve. So if you do even a 23 nominal with a mean diameter 21, 20 or so, you can risk root injury. So in this case, we would have taken at least 1, maybe even 2 cc out. This is an 89-year-old, obviously extreme risk, so surgical conversion will probably be impossible, futile. So I think we have to keep that in mind.
Okay. I have a question about this root angle and then positioning of this self-expanding valve.
So I think the point is that on CT it looks like anything 60 or higher is considered horizontal root. 70 is more extreme. You can see the aortogram you discussed earlier was a little bit less. But I think the point is that with the tracking of a self-expanding system, because there's no active flex, right? And so you have a capsule, so you have to be mindful to make it coaxial. And I think the FX platform has been able to do that better than the previous generation, I would say Pro or Pro Plus. So.
Yeah, the height, coronary height wise, I think you can say 10 millimeters.
Yeah, I think the coronary height is a good discussion here, because now let's say this is not an 89-year-old, it's a 69-year-old, right? Then we talk about lifetime management. I think you talk about the coronary height being about 12.1 and 19, so they're tall enough that when you put a self-expanding supraannular platform, coronary access.
What is acceptable?
10. I mean, I wouldn't say there's a cutoff. I think 10 or lower would be considered low coronary. Left main is typically lower than the right, just by the nature of the anatomy. We've seen that in surgery. I think the concern also, remember, is not just the coronary height, right? Each valve has its own inner sealing skirt. You need to know that. And back in 2018, when we published the coronary access paper in JACC, we actually outlined all the different valves for SAPIEN Evolut on the inner skirt height, so people is aware. Because it doesn't matter the height of the valve, it's the inner skirt height that cannot be modified or changed. And so you need to know that in case the root is small and the coronary height is low, you have to pay attention to that when you attempt coronary access, or even now TAV in TAV.
And so simple principle of 10 of the coronary height and 30 of sinus of Valsalva. If the 10 and 30 both are negative, combine, if both are there, more chance of coronary obstruction. Any one of them, less chance of coronary obstruction. None of them, very minimal chance of coronary obstruction. So 10 and 30 is the one which we teach everyone with the numbers. Yeah.
Go back. What's your question there?
Yes, Dr. Nagoyen formulate the same question. He says, I can see the annulus is elliptical. Can I ask, what is the maximum ratio, minimum to maximum, of annulus that makes the valve constrain expansion and or causing central leak, self-expanding or balloon expanding in elliptical cases?
Yes, I hear you want to answer that question, because there are some devices that has a limit, right? Like in an Envision trial. So.
Right. So that is a very good question. You don't want to have a lot of ellipticity, 30 to 40% minor axis deviation from your major axis. But what really happens with these newer generation of self-expanding valves is that some degree of eccentricity is okay. What happens is these conform to the perimeter and does not compromise. As long as you're true sized, it does not compromise your leaflet function or leaflet pinwheeling. Now, what happens is if you end up using a bigger valve in elliptical routes, then there is more pinwheeling. And Miho's group actually showed that when you have more pinwheeling, these degenerate faster. So eccentricity and more pinwheeling leads to more faster degeneration and halt. But if you're true sized with these self-expanding platforms, for the most part, the durability is not a concern, and actually you don't get that much pinwheeling.
Yeah, I think further to Sahil's point is that if you use a balloon expander, it will circularize.
Yes.
So if you're very elliptical annulus, beware of annular rupture, because the short axis is what determines how much stretch you're going to get. So there's a calcium on the short axis of the annulus. We get very, very nervous. For a self-expanding valve, because of supraannular feature of the Evolut, is less of a issue, because obviously the leaflet functioning starting at node 3 or 13, 14 millimeters above the inflow. So you're going to have more circularity up there. As long as you have that, you're fine. The intraannular self-expanding valve, there is a defined ratio that you need to look it up in the manufacturer sizing chart to determine if that's appropriate or not.
You should not have more than 30% difference between the minor and major.
That's right. That's what.
At least for the trial. Yeah.
Yeah, for the intraannular self-expanding valve.
Now, the LVOT is narrow. Is there any concerns self-expanding versus balloon expandable in this case?
Definitely higher risk of pacemaker here, Dr. Sharma, if we are doing this case, especially if you end up deploying the valve deeper. And sometimes it's unpredictable, but you want to deploy slightly higher. Smaller LVOTs end up leading to more injury to the conduction system.
Yeah, that's a great point. We've been looking at LVOT anatomy for probably 15 years now. I mean, since we started the program. Most centers don't do it. The reason is that if you have a very small LVOT like this, you have to control the release of the self-expanding valve very carefully, because the small LVOT can push the valve more aortic.
Yeah.
So if you start implanting the valve at 80% quite high, beware, if you not have much calcium, you're going to pop out.
Correct.
So there was some experience of self-expanding valve popping out, and even balloon expanding valve. We've seen some cases where, you know, we inflate and then there's a PVC or there's something, and then it can also move aortic as well. So you have to be mindful of that, and that in addition to what Sahil said about the pacemaker risk.
Yeah, so remember the last month, actually month before, we had the case where less calcium on the leaflet, and we could not anchor the self-expanding, and we had to bring the balloon expandable. Now various technique, I thought just put a balloon on the side could do, but now they are doing that you bring your valve and put a stent. Inflate the stent so that it make it in the stent in the leaflet, and then you expand your balloon expandable. So particularly in a low calcium, that is the technique just described in the JACC intervention last month. I think name is Atlas or some acronym. So that you put a stent just at the level, away from the coronary and balloon expandable, or any, they actually picture is of the balloon expandable, but you deploy the stent at the same time you're inflating your valve. So what is happening is, because of this friction, the valve will not move, like the case which we had about 2 months ago. Okay, with that note, I think we go on to our now performance. I know what you want to cross this valve with, any
Nothing.
special wire or?
No,
Yeah.
usual. Let's move on.
Which is our AR2?
Yes.
Any questions, Dr. Moreno, from the audience so far?
Yeah, well, the question about the maximum ratio,
Yes.
minimum to maximum, like
Yeah.
here we have 17 and 25.
Yeah.
So it's like 50%. You know, 17 divided by 2 is about 8. 17 plus 8 is 25.
Yeah.
So that ratio will be 50%.
Yeah.
What would you say, you know, for
So I
very
think what Sahil
elliptical?
mentioned what Sahil mentioned is that for intra-annular self-expanding valve, don't exceed 30%.
Okay.
30%, yeah.
Yeah.
Okay.
So for supra-annular, there was never any criteria on the in the trial, or balloon expandable valve. So the only thing, like I said, you have to be mindful of is that if there's calcium at the annulus or outflow tract in the minor axis, because when the valve expands or when you try to manage the paravalvular leak, you go to post-dilate, and the balloon size will be bigger than the minimum diameter. So you have to be mindful of the annular rupture risk. I think that is probably the most important information for the audience to understand, that the ratio is more critical in terms of annular rupture with
Can you
heavy
show the
calcium.
gradients, please?
Show the hemodynamics on one side, please.
In the bottom. Okay.
No, wait 1 second. Yeah. Very high gradient, as you can see there.
Not echo, fluoroscopy.
Can we see fluoro and hemo on the picture-in-picture on the left side?
Yeah, good.
Left side, please. Bottom left, if you can.
No, you
Yeah, for the
cannot.
hemodynamics.
Yeah, hemo should go to the left side, yeah. Not on the right, just bring it to the
As
left.
we
Okay.
typically do.
Can we go RAO, please?
Okay, we cross the valve. Now you're advancing AR2.
Yes, so AR2 is across. Now we're going to switch for a
Thank you.
pigtail. Again, the same technique, atraumatic J-wire all the way in the apex. How much volume have we given?
Do we need BAV?
Walk it out.
Can we go for a leader,
We have
please?
to do a BAB. Can we give a liter, please?
So one thing we do a baseline echo, you can see earlier when what Stam showed us was that the ventricle was very empty. It was very thick, actually, if you look at the long axis. So we typically like to give, depends on the size of the patient. This patient, remember, has a BMI of 29. So I think a liter volume is appropriate because, remember, that typically they're MPO after midnight. So there have been 8 hours minimum, if not longer, of no really IV hydration. So you can certainly start with some IV hydration up there. We do that for patients with advanced kidney disease, because we want to minimize IV dye. We want to hydrate the patient and protect the kidneys. The only ones that we are not so aggressive with volume repletion are the low ejection fraction patients, dilated LV. So you don't need to be too much of that, or very
or dialysis patients.
old, dialysis patients or old frail patients, very small BSA or BMI. So those you don't need to do too much because you don't want to put them under pulmonary edema either. But certainly, you can see the pigtail here. You don't want to be what we call a pancake, meaning that you don't see the circle of the pigtail. When you exit with the wire that Sahil's doing now, Dr. Kinney, you should see that wire in a loop that is more in a circle facing you.
Yeah.
So you can see how pancake it is. So this is a risk of LV perforation. So the only way to fix this is to increase the preload, the volume, because remember, you see the calcific AS. So the operator cannot push the wire too aggressively, especially if the patient is chronic steroids or on immunosuppressant. Those are very fragile. Our last LV perforation was about 5 years ago, and that patient was on steroid. Also, a small female, thick ventricle. Also, that's another risk. Elderly female. So be careful when you have an elderly lady. This is a Safari extra small. That's the smallest pre-shaped wire out in the market. There's nothing else smaller than that. It's a very, very forgiving wire. They use it a lot in Asia because of the small profile. A lot of patients in Asia are small. So you just have to watch this wire very carefully when you do your TAVR procedure, okay? Because you don't want this wire to be out exiting the LV.
And you're ballooning it, what size balloon now?
20 true balloon
for you.
And then we will use
Okay, 150.
22 for post-dill. 150, please.
So you can see here the balloon markers have to be across the leaflet.
Back up.
Not the LVOT, not the aorta. So otherwise, remember, small outflow trap, when you do the BAV, it can slip up.
Yep.
So you have to make sure you have enough purchase in the ventricular side. And the first operator sometimes may have to apply a little forward tension to avoid that from slipping up. And obviously, we pace at 150. You don't have to pace. BAV, you don't need to pace. But just keep that in mind so you don't end up doing multiple BAVs, because obviously you can risk acute AR as well. So something to keep in mind.
And a selection, the size of pre-BAV balloon.
That's a great question, Dr.
Usually
Shaw.
the minor.
Correct. Yeah, so going back to your point, Dr. Moreno, we typically do minor.
Yeah.
If you are not as wary, you can do the same before and after.
Yeah.
But certainly for self-expanding valve. Balloon expander we typically do not need unless it's heavily calcified bicuspid or heavily calcified valve. You worry about not able to cross a balloon expander valve. That is probably the biggest concern that you might need to worry about. So let's look at the hat marker. Flush point at 3 o'clock. You can see its outer curve. Tracking nicely. And it's going to go, we're crossing the valve, Rafi. Okay, we just crossed already. Yeah. So we're going to go now to...
So what extra precaution you have taken for FX Plus to be aligned with your coronary ostia?
So first of all, the hat marker has to be in the outer curve when you cross.
Right.
Second point is that you need to have the hat marker now facing you, and when you deploy your depth, your dots should be. This might be a little bit extreme. We might not be able to do it.
Yeah, too extreme.
Yeah, so we have to go a little bit less RAL, and then go a little bit more caudal.
Okay.
And you can see that here. Okay, so.
Can you center this for me so I can see?
So yeah.
Good.
Yeah, you happy with the centering or?
Yeah, looks good.
This is better, Gilbert.
Yeah. Okay, I think we're a little deep to start.
Okay. Yeah. Good. Give me a gentle test. Excellent.
Pigtail is not at the bottom.
Yeah, pigtail is it at the bottom?
No.
We'll be okay.
Still high.
Okay.
Still high.
Yeah.
Don't push.
Yeah, no, it's it's the calcified leaflet.
Yeah.
Okay, 150.
Fluoro. Inject.
Pace at 150, please. Good. Okay, 100, please.
100.
So we never stop pacing because you don't want to be popped out the valve. Like I said, remember the small outflow tract, right? So you don't want to be too shallow either. Rafi, can you remove the Christmas tree up top for a little bit, please? Thank you.
I really like this.
Okay, so let's take a look. So line up the 3 dots, then you take the parallax out of the Evolut. It's very clear.
Oh,
Okay.
it's lifted up on the.
So it's a little bit high on the left. You see that?
Let's do a recap.
Okay, so we're going to recapture a little bit.
Not partial. Full.
150.
150, please.
It went in already.
Test here.
No.
Low
We need to
puff,
go in a
please.
little bit more. Left is still high.
Yep. So we like to do a full recapture. Pull
Yeah.
the wire back a little.
Yeah.
Good.
Pull back. No.
Okay,
It
wait,
came
okay.
back.
Yep. Good.
Go in.
Better.
Okay.
Okay, 100.
100.
So you can see it's now 3 millimeter on the non. Good.
Yeah.
Okay. Yep. It's 1 on the left.
It's still a
Yeah.
borderline on the left.
I would okay.
Let's
Oh,
give
good.
it a couple of minutes.
Any questions from the audience?
Calcium is
So
on the
far, so
leaflet.
good.
Yeah, the leaflet. Yeah.
So this is the challenge with horizontal routes. Underappreciated challenge.
Yeah.
that
When you have
make.
horizontal root, it's less symmetric, but that's okay. It's better than previous generation. So.
Give me a 2-minute timer.
Now, Sahil, when you mention that for this small annulus, you have to take into the account the body surface area for the mismatch. What do you do if you have a small, very small annulus and a large BSA?
I think surgical options are always on the table. So we should discuss surgery with them, especially root enlargement or low-risk patients. Even Ross procedures can be done. If not, then we have to think about supraannular self-expanding platforms.
And remember, in small patients, the small annulus, when the trials have done, compared TAVR versus surgery, the patient prosthetic mismatch is higher with surgery because they cannot go beyond certain size unless you do the enlargement of the outflow tract, which is rarely done. I mean, they do it, but less. So overall, because of the valve size, we are less PPM.
I like it. I like it very
Nice.
much.
Yeah, he
I like
pushed
it
in
very
actually.
much.
No, you're good.
Okay. All right.
Oh, pull the wire back.
Okay. 150. We're gonna release. So we do a slow release, especially for small outflow tract. You see how we kind of slowly, one tap is out. Okay, the second tap, waiting for the second tap. The second tap is not out. You can see that. Okay.
Keep pacing 150.
So you
Doc,
have
can you
to
hold the
make
wire?
sure. See, the tap is still caught. Okay. Because horizontal aorta, so you have to kind of
Just give it some
slowly,
time.
gently massage it.
Rotate.
Rotate.
Pace at 120.
Keep talking what you're doing.
You want to
Yeah,
Keep rotating it.
We're clocking it.
Clock, counter clock.
There you go. See
So
it?
it comes off.
Yay.
Okay.
So you have
we
to do
forsake
clock, counter clock. And then
that. Okay.
what you do is, you see that? I'm
Yeah.
advancing the wire.
So the nose
slowly.
cone has to be centered. Dr.
Yeah.
Kinney's
Yeah.
pulling back the
First
wire.
you pull the wire
And
back.
then now
nose-
she advances the wire. Yeah, go ahead.
First you pull the wire back, then it is centered. Then I advance the wire. I'm advancing it more, you see that? And then I'm bringing it back.
Excellent.
Yeah.
Get me a 22 true balloon, please.
Okay, so when you're in the descending, then you recapture here. Your left hand to the right hand so that you don't push the capsule. Okay, good. Back up now,
Mag
please.
out, please. I want to see.
Yep.
Let me mag out.
Okay, come out.
Good. Good.
In many people actually in these small annuli use the self-expanding and leave it for 5 minutes before they develop.
Yeah, we used to do that, Dr. Sharma,
Yeah.
especially the older generation.
Go.
Now we really don't, but
Yeah. The newer generation self-expanding are better in terms of, like, this would be a
Can we
tough
take
case
a
from
pigtail?
a
let's take a picture.
older generation standpoint.
Toro AK.
You mean to diminish the paravalvular leak, SS?
No, to
No,
make
no,
a good
for,
annular
Good
contact.
annular
Yeah.
contact.
Yes.
So remember, self-expanding
Takes
it will
time for the
take
nitinol.
time for the nitinol to
For
expand.
the body temperature.
Let's do a picture here.
Mm-hmm.
Go ahead.
Move.
Yeah.
He went down.
Canted a little. Let's post dilate.
No.
Now we are doing a 22 millimeter.
Why is it?
True.
I think the pigtail was on the leaflet.
No, this is okay.
No.
That was, but it way too much down, but now it's okay.
Very careful. Yeah.
Okay, so we take the parallax out to do the post-dilatation so you can see what's going on. We typically do the aerial caudal view because you want to see the short axis. In case of hostile anatomy, you don't have to go all the way. Remember, you can see how it looks.
Okay, 180.
Hold the wire. Anybody hold
I'm
the wire?
holding it.
He's holding.
Yeah, now expand it.
Continue pacing. Continue. Slow. Okay, advance.
Okay,
good,
back up
perfect,
pacing,
back up.
please.
Get a pigtail.
Let's do hemodynamics.
So when
So
you
it's
have
very-
deflated the balloon, you deflate the balloon, continue pacing. When it's completely deflated, then only you have to
Yeah, that's an
remove the
important teaching point that Dr. Kinney just brought up, that you have to see the balloon deflate, right?
Yeah.
So that's what she was saying. Any comments, Dr. Kinney, you want to add on that?
Pressure
So,
didn't go.
doing this for so many years, Dr. Sharma and AK, how often do you do post-hemodynamics now with pigtail and, the pre and post? Remember, you used to do it?
So I think part of the trial used to be,
Yeah.
but at this time we do it
Commercially.
patients with the valve and valve.
Yeah.
But particularly that you have how much you should expand further. You want to bring the gradient to around 10. The valve and valve. If you have 3 times valve and valve, you definitely have to be very careful and hemodynamic and then optimize.
The other one here.
But otherwise not needed because echo is very good.
1 second.
The echo 5 millimeter means 0 gradient for us.
Disconnect this.
Echo will always say 5 to 7 millimeter gradient and usually 0 on hemodynamics.
Do you want to do echo yet, or you want to wait?
No,
Let's show the hemodynamics.
want
We
to show
take that out and
hemodynamics,
then let
please.
them do echo.
Look
Okay,
at that.
Let's say 0 gradient. And echo will say 5 to 6.
Okay.
Yeah,
Good.
and the diastolic of the
Yeah.
aorta is way
Very good.
distant to the
You want to take this one
end-diastolic,
out
yeah.
and let them do echo? Fluoro? Good. Okay, let's do the echo now.
It's gone.
You proof. Let's go.
Did the
So you see a new left bundle branch
yeah
there.
EKG changed, right?
That's
Yeah.
okay.
No, it's not okay.
We'll get better.
So the
Yeah,
concern
you have
here,
to do it.
Dr. Moreno, you have a very small LVOT, right? And that's what AK had pointed out, that the left is missing, and we waited a couple of minutes. When you try to release, when an LVOT is so small in a patient who has critical aortic
Probably wire
stenosis,
through. Wire through.
there's nothing through.
Everything is out.
So they tend to pop out on release. That's why we waited for 2 minutes, wanted to make sure the left was actually lower than the annulus. So all 3 dots were actually lower than the annulus, and we
beautiful.
felt comfortable. Now the trade-off is you may have conduction system disease, right? Because you're trying to go a little bit lower in a very narrow LVOT. So this, I think, is a good result because you got away with the left bundle branch block, otherwise a stable rhythm.
Go back to the after final release.
Trivial.
Did it really go down?
Trivial to minimal.
No, next.
All right. And what is the gradient?
Yeah, I measure the velocity. Dr. Sharma, 1 minute.
Show the active echo, please.
Okay, take the velocity.
Yeah.
It's a full diamond.
8 and 4. 8 peak. 4 min.
Yep.
As you say, Dr. Sharma. Yeah.
Yep. Equivalent to 0 on
yeah.
angio.
Okay, prof.
Hemodynamics.
The 3rd chamber.
Beautiful.
Okay, great.
All right.
Let's accosta, vamos a accosta to finish up. No effusion. Yeah, looks great.
Great.
Fantastic. All right. So now what will be the next step, Sahil? What you're going to do
Nothing,
now?
we're going to
I think
close
we're
the
doing
groin.
more
We
aortogram
close
or
the
no?
groin and we listen to your slides.
Yeah, but closing it with a 2 per close, 1 per close,
2
1
per
angio
closes.
seal or what?
2 per closes.
2 per close.
Yes.
Okay. Now, what about the single access which people are promoting to decrease the vascular complication? The same artery you puncture above and below?
Yeah, no, we do it if there is an issue with the alternative groin, but for the most part, we don't have to. We still do our traditional approach, 2 axes.
Okay.
Second patient is done. Second patient.
All right. So with that note, Pedro, if there's no more question, we go to our slide presentation, please.
Please go ahead.
Yeah. So I'm just going to, we try to show as latest data have come, and these are the one which is big discussion about the Evolut low risk 6 to 7 year data, then stroke risk after TAVR, protect head-to-head trial, and pro-TAVI trial, and the use of this GLP SGLT2 inhibitors in TAVR. So just very simple. The one have been a big, I would say, surprise in our interventional community until now. The data we have 6-8, even the core valve notion trial original, there was no difference in the valve degeneration, rather less valve degeneration with the TAVR valve compared to surgery. All those cases were the core valve, original one. But now with the various Evolut which were used for the low risk cases, comparing surgery versus Evolut low risk basically showed little surprises. So surprise in the sense, the major outcome of the death, stroke, combined, no difference. As you can see here, clearly, of course, the pacemaker higher that we knew. The valve endocarditis, valve thrombosis, no significant, actually less valve endocarditis, but all the major points as shown in this graph completely equivalent. Now, what was the surprise was here, the valve degeneration, reintervention cumulative through 7 years. So what found is that it's not because of aortic stenosis. So it was 3.8 in the TAVR versus surgery 3.5. What happened is was showed more aortic regurgitation, 5.6 versus 1.6 in the surgery and 5.6 in the TAVR. So basically significant aortic regurgitation at 6 to 7 years, and that became significant. And that is where the whole issue came in, that higher valve degeneration of this Evolut valve and why that happened. Now this basically is, the question comes that did you do off-guided or on-guided post-dilatation? Now remember, there was no true guidance until the middle of the trial when we learned that don't over-dilate. You need post-dilatation, but has to be appropriate, not off-guidance. And off-guidance is the one which is associated with more aortic regurgitation. And this actually have shown if you take the valve which were used in this trial, Evolut low risk and subsequent generation, the 3 valves, the core valve, Evolut R and Evolut Pro, we don't even use them now. And one of the biggest one was the culprit 34, Evolut R. You can see there now, 33% of cases. And many of these trouble, although other valves have also, but many of this trouble happen with a 34mm Evolut R. Now why? And basically what we are doing is, we were try to expand the middle part skirt of using the appropriate balloon, not the on guidance that what it should be. That we are going to 26, 28 millimeter, and that was basically where the valve is, the leaflets are stitched, they cause the injury. And that until I would say middle of the trial or maybe clinical practice, actually not even middle. I remember that was only after the trial was done that we started understanding that this is the issue. I need comment from both of you on this aspect, that what exactly we learned, not only for the 34, but others also, that what should be off-grid or on-grid the balloon dilatation post. You need to do post-dilatation. There's no question on that. But question is, what size will be the post-dilatation? Both of you, one by one, yeah.
I think this is a very important slide. If you see the 34mm valve, that has a very small waist relative to the inflow. So the waist is 24, the inflow treats a very wide range of diameters from 26 to 30. So in simplistic terms, if you were using a 34 valve, that patient was ideally suitable for a balloon expandable 26 or 29. Right? So the annulus would be a balloon expandable 26, 29. But the waist is only 24. If you use a post-dilatation balloon of 26, 28, that means you're going 2 to 4 above the waist diameter. That means you're actively damaging that suture line where the leaflets are present. So that's why I think 34 became a real issue. Not so much the 20 and the 22 waist, which is in your 23 and 26 valves, because you're still 1-to-1 sized with your treating diameter. But the 29s and 34s, because of that waist, inherent waist, you have to be really respectful and mindful of the IFUs. So 29, I would be very skeptical using more than a 23 millimeter post-dilatation balloon. But 34s, I really don't have an answer, because if I have to post-dilate, I have to really post-dilate to what my treatable annulus is. And most of these cases would fit a 26 or a 29 valve. So that's why I think for us, at least, doing 34 Evolut is not really an option. I think till 29 we are okay, but 34 we really get skeptical because of the exact reason.
But in the trial, 1/3 were 34.
That is correct, 33%.
So the question basically is that this is the key slide. Remember the waist. If you go beyond the waist, then they call it off-grid. And we were dilating Evolut R24 with a 28-29
Right. Yes.
routinely. And that basically caused that, looks like the damage. Now, remember lower they wrote down 26-30. That's what we are doing at that time, treatable annular size. But then the message came, they call it a field corrective action, FCA. So they've learned by putting this, you're causing many of the more regurgitation, acute damage. And then the recommendation came at this from the company that don't use beyond 26 millimeter, right? It was, what did it came exactly?
It was 25 millimeter, 25 millimeter for the 34.
Yeah, 25. That don't go beyond 25 millimeter in Evolut R34. And that's just to say, but it was too late for the trial. And that really created this trouble. And now it's happening at this level. And you can see here FCA, which is the field corrective action. Once you learn that, the top one is 34 millimeter. Look at that basically in terms of the leaflet damage. Really decreased learning from it. The same thing, the price you pay. That when we, many of the trials when we saw accurate neo, we were not doing enough dilatation. And by the time the trial was done, accurate neo has a more PVL and more outcome, bad outcomes, and that while the valve has been taken off the market. So same thing, we learn it, but we learned too late. Because the trial basically was done by 2020, actually 2019, 20, and that's where we have the now 7-year follow-up. They actually have a 6-year, some cases 7 years, so they extrapolated in the remaining patient for the 7 years. So it just showed that 7 year got more trouble than 6 year. Now, is there any related to particular valve in terms of the mortality? Answer is no. So valve degeneration is one issue. Mortality is totally different issue. So there's none of the valve associated with higher mortality. But we know this post-dilatation with the off-grid dilatation, they call it, associated with higher reintervention, largely mediated by aortic regurgitation. And I think based on this, you see in the right bottom, reintervention cumulation of 5.5 versus 9.8 in the TAVR group, and it was 3 and 6. In the surgical group. Just want to say again, there was something done to the leaflet because this phenomena we did not find in the notion. So how do we explain it? Because notion 10 year, actually you had a little trend towards little higher valve degeneration in the surgical side compared to the core valve. In the notion was all cases were higher pacemaker we knew, but in terms of valve degeneration was not seen at 10-year follow-up in the notion.
Yeah, Notion trial was an older trial with majority low-risk patients, age of 70. And the valve used was the 31 valve back in the day, wasn't the 34. So the waist ratio wasn't that much. So even with a 31 valve, you would rarely use a 29 balloon or a 28 balloon, and there wasn't that bad a waist ratio. So I think and also there was not a big trend of post-dilatation back in the day. This is an old trial looking almost a decade and more back. Now we are more practical about doing post-dilatation because not only for PVL and gradients, but also for frame expansion. We want to improve the durability of the valve. We want to leave. So I think there are a lot of things. One is the 31 and the other one is, I don't think we were doing that aggressive post-dilatation for frame.
And I can tell you, I went back to the original paper. They don't describe what was the post-dilatation.
Correct.
In the Notion trial. They don't even describe it. I mean, unbelievable. So could not get the number. Now we do routinely, but they didn't even describe it. I said, let's see what the difference is. Now, Could it be something changed from core valve to Evolut valve frame may have created to this outcome? Because this is a major issue.
I mean, that's theoretically possible, right? Because core valve classic was, been how many years old now? 20 plus years old.
Yep, the first one we did on December 18th, 2010.
So the Evolut's supposed to be a different leaflet commercial design. The frame design was different as well in terms of the nitinol frames, the radial force. So it's possible. But I also would say that we don't know how it will look like in 8 years. Partner 3, 8 years will be hopefully coming out later this year.
But they said that they are not going to show 8-year data now.
Yeah.
They'll wait for 10 years.
Yeah.
So this is 7 year, is skipping 3 years, and now just going to show 10 years.
Yeah, because the
But maybe FDA may ask them to show
FDA is pressuring. I think all companies now for any trial, even the new trial that are coming, Envision, right, the one that with balloon expandable they're coming, Mirrors and Terrace, they will want 10-year data now because of this observation. Because they also want annual reporting. Because this was not seen. At 5 years, there was maybe a little signal, but nothing really concerning. So, but now obviously there's more concern, so that's why they want every year. And same as surgical valves, right? We haven't seen the surgical valve data yet. So far it looks okay, but we've seen that trifecta surgical valve was doing okay, and then suddenly, went down the hill because it just precipitously failed because of AR. So we may see that in the surgical valves as well. So we have to see how it looks like 8, 9, 10 years for all platforms.
I think it will be good to see 8 years because remember at 7-year data of the partner 3, again low risk, there was a higher the valve thrombosis.
Correct.
Significantly higher valve thrombosis like 5.2 versus 2.4, but not a degeneration, but valve thrombosis. Here, valve thrombosis was equal except lower endocarditis, but price was paid by this aortic regurgitation. And of course, we had to get over with it. So this is a nice editorial by Gupta and David Cohen. That's basically showing that clearly in this low-risk patient, they reinforce the critical role of heart team-based discussion that transparently address both known benefit and remaining uncertainties for patients considering an intervention for treatment of AS. Moreover, this report exemplifies the critical role that high-quality clinical trials and transparent reporting of clinically relevant outcomes play in shaping the future of intervention for valvular heart disease. With adherence to these standards, as demonstrated by the investigators of the Evolut low-risk trial, we can continue to iterate both devices and procedural technique for the benefit of a program. So key is on-grid versus off-grid clearly showed once you got the off-grid, they had higher aortic regurgitation. So there's then a few other simple publications which I want to go through. Stroke risk after TAVR, basically from the data from a TVT registry, large number of patients they wanted to see, is there a difference in balloon expandable versus self-expanding? As you know, the ratio is about 3 to 1. 75% is balloon expandable and about 25% is the self-expanding valve. Some criteria difference, but just let's go back to regurgitation. No difference. Aortic regurgitation, paravalvular leak clearly higher in the self-expanding valve, and the gradient was actually lower in the self-expanding compared to balloon expandable, but all other individual endpoints were not different. The stroke was kind of a little neutral, trended to be, but non-significant with the two valves. So basically showing that both valves are all good. What is the trouble is for the stroke that it shows you the femoral access have a lower stroke rate, your high STS score have a higher stroke rate, and prior stroke has a higher stroke rate, and of course goes with the age. Typical factors which we have seen in earlier trials. So then the next study was that this field of the cerebral protection has not died yet. There's still very companies investing into it. Protect the head-to-head trial, Protect H2H, comparing this new device, which covers completely all the great vessels. Because with the Sentinel, it was blamed that you are not covering the vertebral, about 20% of the left vertebral. Maybe what if you cover the completely? And as you can see here, this device covers completely all the three great vessels. So therefore, it has a full protection of the embolism. So those were the two primary endpoints, emboliner and versus Sentinel 1:1, 500 patient. The of course, the 30-day composite endpoint was Mackey, stroke and sober. Second point they had is number of particles captured which are more than 150 micron. They wanted to just show the proof of concept by covering all, we are going to increase capture of the 150 micron. So it was 70% balloon expandable, self-expanding. As you can see, everything was good, and outcomes were no different. Now, they compared against Sentinel, but now Sentinel is being compared against nothing, which we have been in 2 trials. So basically showed no difference in terms of primary efficacy, secondary efficacy, but the secondary endpoint of the debris more than 150 micron. Emboliner captured more debris compared to Sentinel because of the bigger coverage of the arch, as we saw. As I said, individual endpoints were not different in this trial, but except the high 150 micron particles were more captured. So what does that mean? It didn't translate into a lower stroke rate, but that's the way it happened. Now, another big controversy. PCI again comes back. Remember, we have so many trials we had done, one negative, one positive, now another one pro-TAVI. That when do you do the PCI, or should you at all do the PCI? So this was a pro-TAVI done from the Netherlands along with the TAVR, patients who have multi-vessel disease. We know based on the data, until now, the guidelines are PCI is a 2A indication. The only large vessel, particularly those 90% stenosis and vessel is more than 2.5 millimeter. They still have not made it class 1 because none of the trials have shown that PCI in the TAVR patient is better. So therefore, a TAVI patient or TAVR patient is better. So this pro-TAVI came up with the same concept that you do with PCI or do the deferral of PCI. So PCI basically, as you can see, assigned to PCI group, then do the TAVR compared to deferral of TAVR, deferral of PCI in the TAVR patients. As you can see here, overall randomization happened in about 13 days. And after the procedure, the TAVI, as you can see here, 93% TAVI and multivessel PCI in 28%, some of them stage intervention. And it was 55% balloon expandable, 45% our self-expanding valve. What were the data? You see the primary combined, but death, myocardial infarction, and stroke, all identical between 2 approaches. So basically, whether you defer it or you do it at time 0 was no different, except the major bleeding was higher. Now, if you think about it, that the red line is like, question is, red line because of overall factor is blunted with the major bleeding, which was one of the primary endpoints. So the major bleeding, which have been shown by earlier trials also, is associated with higher in the PCI group because of dual antiplatelet therapy. And so, and this is what we saw, non-significant, only significant was the deferral of PCI by having a lower bleeding because of less use of agent, which is shown here in this trial. In this bar graph, no difference in the hard endpoint, but deferral PCI. Now you can say, so then you defer the PCI because there's no benefit except causing the major bleeding. And this is basically came out to be that the deferral PCI has a lower bleeding, all the endpoints were equal, and so could make it a point. Now, this is totally contrast to the Notion 3. Notion 3 actually had a lower ischemic event when you did the PCI compared to deferral of PCI or no PCI. The bleeding was slightly higher, but death and MI was significantly lower in the trial. So now we have the contradictory 2 trial data, and what is lead to the guidelines we do not know, except that the major bleeding, one thing for sure, once you do the PCI, more will be major bleeding with the PCI group, and that has been consistently shown by all the trials. So last, just to come it up, just like a DAPA-TAVI, which was done patients after the TAVI, TAVR, here is the GLP-1 receptor or SGLT2 inhibitor. In those patients, they did a data analysis from the surgical data. Both GLP-1 actually had a bigger benefit compared to SGLT2 inhibitor. And if you combine both, if person is taking both, there is a significant benefit of the death, lower MI, heart failure, except stroke risk was slightly higher. That is consistent, and arrhythmia, very important. Once you have both of these agents, there is a lower arrhythmia and of course lower event rate. This is just goes to extension of these agents, which kind of every trial have been done, always positive
Yeah.
in this favor. I mean, now they probably can start do the work against cancer. I'm sure it will come positive. I mean, I've yet to see an agent so positive, particularly GLP-1 and SGLT2 has become the routine standard and so. So let's complete the long-term follow-up Evolut low risk comparing TAVR versus surgery suggested high reintervention rate in the TAVR group due to higher prosthetic AI, largely mediated by valve degeneration and higher balloon pressure. 10-year data are awaited. Maybe they will get an 8-year data, we do not know. Data from TVT registry, but 8-year will not be different here. Only question is, are we going to see 8-year degeneration in the partner 3? That's the only one. This cannot be better because we saw the 6 and 7, big difference. 8 will not be good. But only question is that do we see, is it a valve, only self-expanding phenomena, or is it a general TAVR phenomena? That we need to see. So data from TVT registry showed stroke, balloon expandable or surgical, and it's usually a minimal difference. Then the newer embolic protection device was as similar to Sentinel, but does not matter. It's not going to roll down. Hence, there will be no impact on the declining cerebral protection trend. Then, basically, the randomized trial showing the Pro-TAVR is no good. But then we have now 2 trials, Pro-TAVR and activation trial, again Notion 3. So where things will settle, we still have to see. And the biggest answer will be the large trial of the 4,000 patient complete TAVR, which is about, it got a slow after Notion 3, and I'm sure after Pro-TAVR number will start increasing again, but they say it still will take 3 more years for trial to complete TAVR. We are enrolling as much as we could do in the trial, and let's see what happens. So that will be the final answer into this field. So benefit of these funny agents, I call them, will work everywhere and should be given routinely to post-TAVR patients. We don't do. Even DAPA, based on the DAPA NEJM paper from Spain, showed that DAPA, I mean, if patient is not on drug, we don't start it. Any one of you? I know you want to say any? Yeah. But they are good agent, but we have to change our practice. Very quickly now, we are getting to our time. Following are the findings of Evolut low risk trial comparing TAVR versus surgery, except similar valve intervention between surgery and TAVR, similar death rate, similar stroke rate, higher new pacemaker in the TAVR versus surgery. Clearly, A is wrong. It's not a similar valve intervention. It is the higher intervention in the TAVR group. Second, following statement is false about the results of Pro-TAVR trial compared to PCI versus no PCI, similar death rates, similar major bleeding, similar stroke rates, and similar TAVR valve types between 2 groups. Our answer is B. There is a higher bleeding in the PCI group. Lastly, following statement is not true about the finding of the PROTECT head-to-heart study comparing new emboliner versus Sentinel cerebral protection device, similar primary safety efficacy between 2, similar stroke rates between 2, similar debris count more than 150 microgram between 2 groups, and similar vascular complication between 2 groups. Clearly, that emboliner collected more 150 microgram debris, but it did not translate into any decrease in the overall stroke rate or TIA. With that note, I complete here. Pedro, if any questions, we'll love to answer them.
Yeah, no questions, Dr. Sharma. Thank you so much for the heart team, but thank you for joining us today. It was this amazing case. This case will be available for your review as soon as this afternoon at ccclivecases.org. And remember, our structural half-life cases occur on the second Tuesday at 9 a.m. Eastern Time. I'll see you next one on May the 12th. Thank you so much.